occupies our minds. It should allow how to differentiate between different psychopathologies and autism.
Hello, my name is Amit, Shalev. I'm a child psychiatrist from Hadasa. I represent with Zili, which is the psychologist of our autism unit at Hadasa, the head of this unit. It won't be a comic relief, but it will be a clinical relief because we'll focus on clinical cases that we have encountered at our ward, inpatient ward at Hadasa. And we'll talk about the challenges of initial diagnosis, which is late onset, being presented as part of a wider clinical presentation, including psychopathologies that are being admitted, young adolescent girls being admitted to the inpatient ward. So we'll start by talking about our department at Hadasa very shortly. And in our ward, we are admitting in every single moment around 14 to 15 cases. Most of them are adolescent girls. The length of the hospitalization is usually around 2 months. However, psychiatric complex cases tend to stay much longer. Anorexia nervosa and psychosis, we will be admitting them for half a year, sometimes a whole year of a very long inpatient care. The male to female ratio at our ward is 15 to 1. Mostly girls being admitted into our ward. The reason is, I believe, related to that our psychopathologies include mainly anorexia and suicidality and depression and sometimes psychosis and so forth. However, without conduct or major conduct problems in which we are sending to other more guarded facilities. And girls usually present with a lower profile of conduct problem as compared to boys who can be or tend to be more aggressive and violent, and these cases are being sent to higher to places with more guard and security. So we see the whole spectrum of cases at our ward. You can see here the whole list, which is kind of the whole spectrum in the DSM-5. And why do we want to talk about adolescent girls and why ASD? So the thing is that at our ward, during the whole period in which I work at Hadasa for the last 12 years, we see many cases who are being admitted due to other causes, such as I said, depression and anorexia and psychosis and so forth. But during therapy, there are many questions regarding the possibility of suffering from comorbidity of autistic spectrum disorder, and many of the girls' diagnoses, such as anxiety and suicidality and depression, which are more prevalent in girls than boys, combined with the fact that autistic spectrum is more prevalent in boys than girls, makes it quite hard to diagnose, and many cases are getting older and getting to their adolescence without being diagnosed with ASD. And now we'll present three clinical cases that were admitted at our ward during this year and that were diagnosed eventually with ASD. So the first one is Miriam. She's 17 years old, a girl admitted due to severe anorexia nervosa, and I'm talking about very, very severe. When you look at her, it's hard to keep your eyes on her because she's very, very thin, and more like the cases that we are seeing in the adult ward, as compared to the child and adolescent ward. During her early development period, she was diagnosed with social phobia, and some people talked about selective mutism. But at our ward, there were some hints that pointed at the possibility of ASD. These included, and these reports are from our clinical staff meetings and from our therapists who took care of her personally, or like her individual psychotherapy at the ward. So her therapist talked about extreme resistance to being in therapy. She refused to enter. She tried to run away each time. The therapist felt that Miriam is like a ghost. For example, she stays at the entrance, plays with the door handle, sometimes leaves the room and waits outside. Her eye contact was sometimes she avoided totally eye contact, and sometimes it was very much intense in a way that made you feel uncomfortable, not appropriately using her eye contact. She spoke with a very shallow and mechanical voice, very unique. If you would hear her, it's immediately you're noticing something is not usual there. She was highly egocentric in her thought processes and behaviors. Miriam doesn't care about the rules of the ward, and she sticks to her own desires totally. Like nothing interested her regarding our wishes toward her therapy. She has a tendency to express herself violently toward the therapist. During rounds at the ward, she was hitting the doors, she was screaming, she was trying to be violent toward us. And later, Zili will present the process that she went through her diagnosis in Zili's unit. The second clinical case is Leah. She's, again, 17-year-old. From a very respected, nice family. Her parents are really, really nice, and they are really carrying along all her developmental period. But only at the age of 17, the question and answer regarding the autistic spectrum was raised and answered. So she was admitted due to suicidality. She had suicidal thoughts, very troubling ones. She didn't know where, still doesn't know why or where they're coming from, but she was talking about a real possibility that she might act by them. So it made us quite anxious about her, and we admitted her. For years she was treated in psychotherapy and pharmacotherapy from her toddler years, okay? Like she had emotional regulation problems and anxiety, social problems. At the ward, her therapist talked about, which is the same therapist, by the way. So she talked about the difficulties in understanding situations from another person's perspective, limited internal emotional world, like Leah couldn't describe the reasons for the emotions she was experiencing. Like she said, I'm sad. But when you ask her why you are sad, she said, I don't know, I'm sad. I'm happy. Why are you happy? What makes you happy? She couldn't connect between her thoughts, feelings, and things that were happening in her life. There was limited internal emotional world. This is I told you about. She could express herself with very limited number of emotions. Like the range were very much limited. Sad or happy, that's about it. She had blunted affect. Sometimes when it seemed that she's experiencing a negative emotion, she denied it, and she reported about problems in her childhood with eye contact. She was saying that it was difficult for her to look at other people's eyes, so she adopted behaviors such as looking at the other person's mouth, for example. That way she looks maybe normal, nobody noticed that she doesn't really look on his eyes, and this is what helped her overcome this uncomfortable feeling. She had a hypersensitivity, a sensory hypersensitivity during her childhood, and she has superficial relationships with her peers despite yearning for meaningful ones. Like she was talking about meaningful relationships in the ward sometimes with other patients, but we saw very shallow and the opposite of deep relationships. And the last one I will talk about, and then I will go away and Zili will start her part. So Elizabeth, we call her Elizabeth because she's like the Queen of England, the way she is dressed. She looks like she's 14, but she seems like 30 year, 25 years English woman who is very much aware of what she's wearing with necklace and everything. And she came also due to anorexia nervosa. The hints in her therapy included a sensory sensitivity to noises and touch that she was talking about. Very monotonic speech. Very quickly after you start speaking with her, something seems wrong. Very monotonic, and she would switch subject in the conversation without making sure the therapist is aware of them. She was very concrete in her cognitive processes. For example, when asked how did you get to the ward, she would say by car, and she wouldn't explain the reason in which she came for. She describes tremendous emotional pain for years, mainly related to social difficulties at school and other activities in her life. And her father seems like an autistic who was never diagnosed. It was also something that we have noticed during therapy. Yes, so thank you, and Zili.
Amit will return soon. So about the research procedure and tools. This research that we are presenting is a preliminary case study research. Cases like Miriam, Leah, and Elizabeth are very complicated and require multi-team effort. Usually, these are the cases that we are worried to diagnose them because they are so difficult. So the participants in this case study all had a full autism evaluation with the adults, ADR and SRS. The SRS was filled also by the teachers, both on the ward and the teachers in the schools before which they learned. They also underwent cognitive and emotional evaluation and a full psychiatric evaluation. What was very important to us, sorry, a minute. Okay, is that we had a psychiatric consultation, which means that every person that treated the girls was invited to not even one, maybe 2 or 3 full session, which we considered all the possibilities and decided together which is the right diagnosis and which is the way to treat, and even how to tell the parents and the girls their evaluation, their diagnosis, sorry. Our results. All girls met DSM-5 criteria for ASD, both by the adults, ADIR, and the SRS. The ADI and the adults demonstrated challenges in social communication and intense preoccupation in social relationships and restricted behaviors. Some of the restricted behaviors were the ones that brought these girls to the ward, and some of them was connected to food and all kinds of other strict behaviors. Social challenges from early childhood were reported, although the girls weren't referred to a specific ASD evaluation until the current year. We figure out maybe because their social difficulty were perceived to be part of their emotional difficulties. And also all participants, all the 3 girls, displayed camouflage behavior in social situations, which I will refer soon. I wanted to show you some of the comorbid diagnoses at preschool, elementary school, and the present for all 3 girls, Miriam, Leah, and Elizabeth. So you see that Miriam and Leah were diagnosed before with social anxiety and general anxiety. Elizabeth's main diagnosis at preschool, the Child Development Center, was selective mutism, And the parents was very, very holding to this diagnosis. Even though she was 17, they said she had a selective mutism. This is the reason behind everything, and it was quite difficult for them to understand that it might be some other conditions. Elizabeth also had a motor and language delay. In the elementary school, two of the girls, Miriam and Leah, had also social anxiety and difficulty in adjustment at school, and they moved from one school to the other a few times. For Elizabeth, the parents were more telling some kind of social difficulty, but there wasn't anything clear. As you see, in the present, they had Miriam and Elizabeth anorexia and social anxiety for Miriam and social withdrawal for Leah. So I want to tell you a little bit about the camouflage behaviors. The definition for camouflage behavior by Tony Atwood, is behaviors or strategies that mask the presentations of autism spectrum disorder features in social context in order to appear non-autistic. I have to say that camouflage behavior could be in other disorders, like in depression or maybe even anxiety. But in the camouflage of behaviors in autism, we assume that has a lot of effect on the emotional well-being. The camouflage traits, as you see here in this table, are the main camouflage traits are assimilation, compensation, and masking. The compensation is like finding ways around things. You see in the green that are naturally difficult. For example, forcing themselves to look at the eyes of another person, although it's something which could be even painful, but they assume that this is what is expected from them. The masking is hiding parts of your autism, like in this example, the zipper on the mouth, not talking about something that you are very, very interested because you know it will be, you are not expected to do by the society. And the assimilation is the way that you try to disguise yourself, that nobody else will notice that you are different. Okay, this is something that like when you're meeting a new person, you can be very friendly, even though you don't want to be friendly or you don't think it has anything for you. The camouflage modifies the behavior or presentation of core autism spectrum disorder features, but the underlying, which is very important to see, that the underlying autistic profile is unaffected, meaning that there is a mismatch between external observation on the person, that the person or the girls in our research look like they have eye contact, a nice facial expression, they have a good impression on first meeting, but in their internal life experience feels different. And we saw that Miriam, Leah, and Elizabeth used camouflage behavior throughout their life and therefore confuse the environment. Also, we saw that the misdiagnosis in ASD or the late diagnosis, was causing a lot of pain for them. In the two of the three girls in our research did use a lot of camouflage behavior in new social situations, like when they first came to a new school or like when they first entered the world, but underneath they had a lot of suffer and they both regressed over time to depression and even to suicidal thoughts. So to sum up, all the participants, this is a small, of course, case study research, but all the participants have been diagnosed at preschool age with general anxiety and difficult in emotional regulation. They all had social challenges from early childhood that were reported, but even though they weren't referred to specific SD evaluation, perhaps since their social difficulties were perceived to be part of their other emotional difficulties. The ADI and the adults demonstrated challenges in social communication and intense preoccupation with social relationship and restrictive behavior. And the camouflage behavior were present throughout their life and contributed to the late diagnosis, and we assume to their internalizing symptomology. Amit.
So it's until lunch. I'm trying to make it fast. So we're thinking about conducting further research that would help us understand these cases that were not diagnosed by Professor Sasson's machine learning and got into our work later in life at adolescence, and these cases are much more complex because they gained along the years or accumulated along the years more psychopathologies, more suffering, and this makes it much harder to treat. So we're aiming for a retrospective research, aiming to identify factors that contribute to late ASD diagnosis. We're aiming to use parental mentalization instruments or instruments that measure parental mentalization, parent-child relationship, camouflage behaviors, and all of these in order to enable earlier diagnosis that can improve outcomes. A question that brought up during these processes is the one regarding late diagnosis and its advantages. Like, there's no advantage for late diagnosis, but if there's no diagnosis, so you better do it even if it's later, but there are also costs for that, and these patients that I presented, we keep on treating them nowadays, and there are some questions regarding the benefits that we gain from this diagnosis that we made. And the pros are, of course, it finally gives explanation to their life experiences, validation for what they have been experienced for many years. It can open the door for new targeted therapeutic services for ASD and enable financial aid and more. But there are also challenges that we have encountered, such as dealing with a new and frightening diagnosis. Today in the morning we talked with Corey Schulman, who gave her perspective regarding that, and we talked about how difficult and complex it is, specifically during adolescence, to encounter this diagnosis and to talk about it with the family and the child. A lot of confusion. And some of the available ASD services doesn't really fit the patient's condition. I remind you that they are high functioning, they never considered themselves as autistic, and suddenly to come to an afternoon club of autistic children or adolescents, it's not an easy path for them, or sometimes it won't be feasible. And yes, I think that's about it. Thank you.